Okay, today let's start talking a little about one system, the cardiovascular system. Uh, it's important to understand this system to refresh our concepts of anatomy and physiology of the circulation. Remember that the veins are blood vessels that run in this direction. I mean, all the venous blood that is coming through from the lower extremities and the abdomen. This is the liver. Mute your microphone. Is better. With your microphone muted. Yes. This is the liver, no? So legs and abdomen return to the heart without oxygen. This blood already gave the oxygen to the cells and rich in carbon dioxide uh, through the inferior vena cava, and all the blood coming from the brain, the head, uh, the upper extremities, and the upper chest is coming through the superior vena cava. You know that those veins are called central veins, and the average pressure of the blood in those veins is used to determine the volemia of a person. That is the central venous pressure. So the central venous are those veins, superior and inferior vena cavas. And the pressure of the blood that is inside is going to be proportional, generally, not always, but generally proportional to the amount of liquid, to amount of blood that is inside those veins that are all the blood that is returning from all the body. So is the average of the pressure of the blood in all of the body. And for that reason, we use the central venous pressure, as we commented recently, as a measurement of the volemia. And we use that to diagnose hypervolemia or hypovolemia. And we commented that this central venous pressure is accepted in the majority of the books that is between 5 to 10 centimeters of water when it's measured with a ruler. A nurse can measure this pressure as far as the doctor introduce a catheter in the superior vena cava. Those are the central venous access devices, no? And then a nurse with a ruler, with a simple ruler, can measure this pressure. And it's very simple. It's very simple. Can be learned in the lab, okay? And you measure the height of the column of liquid in the ruler, and this is measured in centimeters. So it's between 5 to 10. If the client has more than 10, it's because the central venous pressure is increased, probably associated with hypervolemia. But if the central venous pressure is decreased, less than 5, is probably because the client has lacking of liquid. Doctors can measure this same pressure in a little more sophisticated way with more sophisticated catheters like the Schwann-Ganz catheter, and the pressure that can be measured there in the vein, okay, because they also can measure the pressure in the pulmonary artery and in the capillaries of the lung. But the pressure measured with this a transducer or computer, the normal values is 2 to 6 millimeters of mercury. So this is the central venous pressure, which is the measurement of the pressure, the average pressure of all the blood that is returning through the main pipes, the main blood vessels to the right heart. You know that this is the right heart. You say, oh, but you separated the right heart from the left heart. Yes, anatomically, they are not separated. You know that. But functionally, yes, they are separated by the lungs because the blood is going to enter first in the right heart, then from the right heart needs to go to the lung. And once in the lung, oxygenate, transformed in oxygenated blood. That's why I draw that red. And then is when this oxygenated blood goes to the left heart. That's why I'm making you understand that the right heart is functionally separated from the left heart by the lungs, by the pulmonary circulation. It is useful because when we are talking, for example, of problems in the right heart, I'm talking about right heart failure, you notice that the manifestations are backward, are retrograde. So are going to be neck vein distension because the vein of the neck drain directly in the superior vena cava. or almost directly, yes. And the veins of the inferior extremities and the abdomen drain practically directly in the inferior vena cava. So that's why problems to move the blood, problems to pump the blood, to move forward the blood by the right heart, yes, moving the blood in this direction, are going to be manifested back of the right heart, back of the right heart. As you see, the neck veins are backward to the right heart. The same as the abdomen, they can have congestion in the liver or even spill of liquid and ascites in the abdomen, and the legs that have edema. So the manifestation of right heart failure to move the blood, because this is the function of the heart, to move the blood. So the heart is failing. So it's not moving the blood efficiently. So what you have, a traffic jam of blood that builds up a backward, retrograde in the to the right heart. So that's why neck vein distension, congestion of the liver, and edema in the lower extremities are manifestations of right heart failure and are very easy to understand if you understand that. Okay, if you understand that the heart is the part of the pump that receives the venous blood. But then this heart, when is working, pump the blood toward the lungs. If the heart is not moving the blood, is not moving the blood toward the lungs, toward the lungs, okay, then the lungs are dry. So that's why the right heart failure, okay, are not going to produce crackles or liquid in the lungs, because if the blood, which is the liquid, is not moving because failure of the right pump to the lungs are dry. So the lungs are not going to have congestion. Yes. So the problems of the lungs are related with what? With the left heart. So the left heart is the one that has the responsibility of moving the blood in this direction at this part, o sea, after the lungs. If the right heart is the one that is failing, then the blood builds up backward. Yes, it's like a obstruction on the turnpike. No, you have a traffic jam buildings up here. Yeah, and that's why the manifestations of the left heart failure are mainly manifestations in the lung, because now the blood, which is mainly water, is going to build up, is going to to see, as to build up here in the lungs, in the blood vessel of the lungs. So now you have too much liquid in the lungs, and because too much liquid in the blood vessel of the lungs increase the capillary pressure, the liquid will spill in the alveoli. Now you have liquid in the alveoli. The alveoli is supposed to have air, not liquid. So that's why when the air enters and reaches these alveoli that are full of liquid, produce these sounds, the crackles, this churning sound of the air crashing with the liquid. But then the client is having problem to breathe. So a person that is not a fish, is not Aquaman, is a person, yes, that cannot breathe water, okay, is going to have problem to breathe if the lungs are with liquid. Can be little liquid, can be moderate liquid, can be severe amount of liquid. All the diseases on this way are this way, no? So depending on the severity of the edema in the lungs, the clients are going to have different intensity of symptoms in left heart failure. If the client has a mild edema, the shortness of breath, the lack of oxygenation will manifest mainly when the person is doing exercise. So these are the earliest stages, stage one, of the heart failure, in which the client presents symptoms only when he's doing an effort. But as the liquid builds up in the lungs, now the person start presenting symptoms even at rest, and the severity of the shortness of breath, increases, and then you notice that the person is having difficulty to breathe when the person is leaning, is lying in flat position. When a person is lying in flat position, all the lungs filled with liquid. Yeah. And for that reason, the person doesn't tolerate this flat position. So the person, what is going to do the person will sit. When the person sits, what happens in the lungs? Okay, the liquid is going to go downward because the liquid follow the gravity force. So the liquids are going to, especially the person sits with the legs depending. No? So now the liquid will accumulate more in the legs instead of the lungs. So now the lungs is going to be free to breathe. So the person is breathing much better when is upright, sitting upright, than when is lying down. So it is called orthopnea. It is called orthopnea, and it's very important. By the way, in the Nclex, they try to mimic the real life. When a person is having symptoms of, let's have heart failure, and are having orthopnea, they don't call the nurse. They tell nurse, I have orthopnea. Okay, do you hear me, nurse? I have orthopnea. Yeah, the clients call the nurse and say, nurse, can you please find 2 pillows more for me? 2 pillows. Why the 2 pillows? Why don't you use the pillows mainly to sleep? And why this client is sleeping with 2 or 3 pillows? Because doesn't tolerate the flat position. So there are uh, scenarios, comments by the clients that you need to follow up because it could be a manifestation of orthopnea. Also, remember that a lot of procedures that the client requires to be, or generally the procedures are done with the client supine in flat position. I don't know, an EKG, mm, different studies, a bed bath, etc. So understand that you need to modify those procedures because this client doesn't tolerate the flat position. You need to modify the technique or the procedure to do that with the patient, okay, with elevation of the head of the bed, because the client with this kind of condition doesn't tolerate the flat position. So this is are the main manifestations of the of the right and left heart failure that are easy to understand, if we physiologically separate the right heart from the left heart, separating them by the circulation. Of course, there are many other details, okay? When a person is having right, so let's go back to right, is a problem in the right heart, uh, a problem in the right heart, the first that we're going to notice is that the legs are going to be swollen. No, the legs are going to be swollen. Why the legs are going to be swollen? Because generally those clients have problems and they are resting, sitting, okay, most of the day. And because they are sitting, most of the liquid accumulate in the legs. Yeah. These accumulation of liquid in the legs are part of the pitting edema. Is this characteristic of the pitting edema? A part of the pitting edema is going to produce an increment of the weight. So fluid retention in any part of the body manifests better when you measure the weight of the client in short period of time, every 1 or 2 days, because the liquid that is retained have a weight, and you know that this weight is each liter of liquid will weigh 1 kilograms. 1 kilograms are 2.2 pounds. So you can even calculate how much liquid a person is retaining if in the day one the client weighs, I don't know, 100 pounds. Suppose 100 pounds, and the 2 days later the person is weighing 104.4 pounds. So this is a 4.5 pounds more. So it is 2 kilos more. So it is 2 liters more, or 2,000 milliliters. Okay, because each liter is 1,000, 2,000 milliliters of liquid retained in these 48 hours. So is a common concept of this client with edema. What else is important in the edema? Edema is always following the most dependent part of the body because, as I said, liquid follows the gravity force. If you have a person with right heart failure and had edema in the lower extremity, but this person go to bed at night, and because noticing that the legs are swelling, elevate the legs, okay? Elevate the legs with pillows. Then you notice that in the morning, the legs are not swelling. But it doesn't mean necessarily that the patient is improving because now the edema is going to move to the most dependent part of the body, which is the back of the client, especially the sacral area. But more than that, because this edema that was pulling in the lower extremities is moving now to the trunk and is in part reabsorbed into the circulation, this person will notice that during the night, when the edema is reabsorbed, is presenting an increment into the urinary output. So the person will be peeing more at night than during the day. Why during the day is not peeing? Because the liquid is pulling in the legs and is not going to the kidneys. Why at night is peeing more frequently? Because the liquid, when the client go to bed, is reabsorbed to the circulation, reach the kidneys, and all the kidneys are going to pee more liquid. So this is called nocturia, nocturnal urea, nocturia. So the client with this right heart failure is going to notice that is going to the bathroom to pee more abundantly, more frequently at night than during the day. So it is another manifestation of right heart failure. Also, this person can have congestion in the liver. The liver is an organ, is the biggest organ that we have in the body. No? It is an organ that has a lot of blood vessels and has a big capacity of pulling blood, accumulating blood, storing blood, and can enlarge a lot. When there is right heart failure, the liver increases in size because it's pulling a lot of blood inside. And for that reason, can be easily palpable even without asking the person to take deep breath, and it's painful because this distension of the liver produces pain. This congested liver uh, uh, compresses the stomach. The stomach is here at the left of the liver and can produce a sensation of fullness or anorexia, and even can complicate in severe forms of right heart failure with leak of liquid in the abdominal cavity producing ascites. So it could be also a manifestation of right heart failure. Um, by the contrary, the client with left heart failure that is presenting all those symptoms, consequence of the edema in the lungs, that, as I said, could be as mild as shortness of breath when he's doing exercise, or orthopnea, can present extreme emergencies. So they are in the question of prioritization. One emergency in heart failure is when the amount of liquid in the lungs is so huge that the person start coughing, cough, cough, if a manifestation of liquid in the lungs, because when you have liquid in the lungs, you try to get rid of this liquid. How? Coughing. And if there is abundant liquids, there is a severe degree of pulmonary edema, you can speed up, you can expectorate some of this liquid. As I said, this liquid is moving from the capillaries of the pulmonary circulation into the alveoli. So this liquid is basically plasma of the blood with proteins and have some red blood cells. But this liquid is churned, is mixed with the air that the person is breathing because the person is still alive. And for that reason, this mixture of liquid with air is going to produce a foam. See, it's going to produce a froth. And but it's going to be pink because the few red blood cells that escape in this increased permeability, in this increased pressure and permeability that occurs in the pulmonary edema. So this liquid is going to be pink and frothy. So when this person starts spitting up a pink frothy sputum, means that this a person is overflowing the lungs with the own liquids of the circulation. So this person is drowning This person is drowning in his or her own fluid. So the level of pulmonary edema in which there is a pink frothy sputum translate is such a severity that becomes probably the client that you need to see first, because this client is presenting a serious problem of breathing. ABC, B is breathing, a serious problem is B in the ABC. So don't be surprised that you have a question which client you see first. They give you 4 clients that need to be seen, but you need to decide which one need to be seen first, and you apply ABC, and you have somebody spitting up with history of heart failure, spitting up pink frothy sputum, and this is the answer. The other consequence of having a failure of the left pump to move the blood forward, is that also some volume of blood that should be pumped forward with oxygen to the organs is failing to be sent to those organs. So don't be surprised that the brain is receiving less volume of blood and less concentration of oxygen as should be. So the brain is going to be very, very, very upset, very, very upset. And when the brain becomes upset, activate the sympathetic nervous system is the fits that the brain do when it's upset. So you expect in a client with heart failure, you expect tachycardia, and you expect activation of the sympathetic nervous system. Yeah, but also you can see certain level of confusion, or or decreased mental capacity, especially in older people that are the one that's more frequently suffer of heart failure. Also, the muscles of the body are going to receive less blood, less bulimia, less oxygen. And you know that we need this oxygen for the production of ATP, for the production of energy in the mitochondria. That's why we need oxygens in the cells to produce ATP. So now you expect muscle weakness, you expect fatigability, intolerance to the physical exercise in the person, independently of the shortness of breath. And something very important and frequently tested. Don't forget that you have here soon after the emergence of the aorta, you have 2 organs, okay, in the upper abdomen that are direct branches that have their which arteries are direct branches of the aorta, and those are the kidneys. The kidneys. So kidneys, okay, are hanging there from the aorta and are receiving an important percentage of the blood that is pumping the left heart. Around 20%, 1/5 of the volume of blood, this is called cardiac output, that is pumped by the heart in 1 minute, is going to the kidneys. Kidneys are going to take this blood, are going to analyze the blood, are going to eliminate the excess of liquid that the person could have. The kidneys can analyze the blood and can determine if you need to pee to eliminate, excrete the excess of liquid. But now, what is happening? The heart, the left heart, is not doing its work properly. So it's sending less than normal blood to the kidneys. So as a consequence of receiving less than normal volume of blood, because the left heart is failing to do this, okay, the kidneys are producing less urine. So less urine is produced. So in left heart failure, as a consequence of the failure of the pump, we can have a reduction in the needed amount of excretion of liquid. What happened with this liquid is going to stay in the body. So the person, because the left heart failure, are going to initiate what is called a vicious cycle, in which the person, because the failure function of the left heart, are going to have a decreased urinary output with more retention of liquid that is going to enhance then the edema that the client is presenting. pay attention that when we have a person with a heart failure, generally are sick both sides, the left and the right, at the same time. But Nclex generally wants you to discriminate, to tell apart which signs and symptoms are due to the failure of pump for the right and which one are due to the failure of pumping of the left. That's why you need to discriminate those symptoms, which is the origin of each one of those symptoms. But uh, in reality, when a person has heart failure, is presenting with both sides of the heart failing, usually, not always, but usually. Okay. So it is an important concept. So, for example, there is one question in Nclex where you are going to apply, that comes to my mind this moment, this concept that you know the relation, the intimate relation between the kidneys and the function of the left heart, okay? That is a patient has left heart failure. The doctor initiate treatment, whatever treatment. How you know that the patient is improving, is responding to the treatment? And the right answer was the patient increases the urinary output. Of course, when you have this patient with heart failure, you initiate digoxin, and the heart becomes stronger to move blood to the kidneys. So more blood arrives to the kidneys, and also is receiving furosemide that stimulate the kidneys to eliminate liquid. How you know that the person is responding to the treatment, and the left heart is returning, is recovering its capacity of pumping blood to the kidneys, the kidneys will start producing more urine. The urinary output increases. Makes sense. Okay. Um, the uh, the the volume. Volume is the measurement of liquids and gases, but especially in this case, the liquids. And you know that volume in nursing is measured with liters and milliliters. Yes, and this is volume. Okay, this is volume, liters and milliliters. And milliliters is the same as ZC. Okay, so you need to have clear what is volume. In the groceries, volumes are measured with all imperial English system, the gallons and the quarts and the pints. But in here, we use only liters and milliliters. Each liter is about 1 milliliters. Okay, so just a refreshment for some of you that are not familiar with this system. So the cardiac output is the volume. So, I mean, the amount of milliliters, no, that the heart is able to move forward, to pump, to speed, okay, toward the circulation in 1 minute. In 1 minute, 60 seconds, 1 minute. Uh, it is established that an average adult person, each time the the ventricle contract, I mean systole, uh, pump or move around 70 milliliters of blood. So each time you have a locked up, no, a beat in your heart, uh, you are spitting in the circulation, moving forward in your circulations around 70 milliliters of blood. But in average, most of us have at rest a heart rate, let's see, around 70 beats per minute. So you have 70 times locked up in 1 minute, beats per minute. If you multiply this, you have the index, the calculation, the concept of cardiac output that was invented by the physiologists. So when you multiply the volume of blood that you pump in each contraction, in each systole, times the time that your heart is contracting in 1 minute, then you are going to have the cardiac output. So in average, the cardiac output is going to be like 5,000 milliliters, no? So 4,900 if this calculation, 5,000 milliliters per minute. So each minute, your heart is moving 5 liters of blood. And this is your cardiac output in normal conditions at rest. Nevertheless, if you start exercising, for example, you start exercising. So what happened? with the heart rate when you exercise. Increases, you know, that increases. So climb the 10 floors of the school through the stairs. Okay, so when you end in the 10th floor, okay, you are going to have probably a heart rate of at least 100, no? At least 100, probably more. So suppose that you keep constant, which is not true. Usually also you increase the cardiac, the stroke volume, the volume of blood that you speed up in each contraction. But suppose you keep it constant, only increase the heart rate. So what is going to be now the cardiac output? 7,000 milliliters per hour. So do you notice how the cardiac output changes, okay, depending on the needs of the body. And that's okay, doing exercise, you need more oxygen in your muscle to produce more ATP to be able to climb all those stairs. Yes, okay. So now the heart will catch up with the increased needs of the of the muscles, the body, to do this exercise, and increases, okay, the cardiac output from 5,000 to 7,000. So it is important. So if you understand how it works normally, the physiology of the cardiac output and the heart, you can understand questions that have been in the Nclex. Okay, Nclex have a question that one easy question. How is the cardiac output in hyperthyroidism? Increase or decrease?
Increase.
Of course, they increase because in hyperthyroidism, your metabolism accelerates because the extra amount of thyroid hormone, and you have tachycardia. If you have tachycardia and you multiply that for the stroke volume, you see that the cardiac output increases in hyperthyroidism and decreases in hypothyroidism, but also can make a more little difficult question. How is the cardiac output in anemia? In a client that have 9 grams of hemoglobin, is increase or decrease?
Increase.
Increase.
And now it's a little more difficult because some things increase or other decrease. Okay, so when you have anemia, 9 grams of anemia.
Compensate.
You need to compensate, exactly. The brain is receiving less oxygen because the function of the hemoglobin is transport of oxygen. If I have less buses, less transporters, okay, now I need to compensate because my brain is receiving less than normal oxygen. And you know how is my brain? Immediately becomes upset and, have these acting out and activated sympathetic nervous system. So that's why the heart will increase the heart rate to increase the cardiac output, and with the few grams of hemoglobin having, is going to make those few grams of hemoglobin travel, okay, speeding more frequent in the circulation, transporting more oxygen. So that's why in anemia the cardiac output is increased. So those are examples in a good understanding of cardiac output, and the relation of the cardiac output with heart rate will help you to answer NCLEX questions that are, as I said before, simply anatomy and physiology class questions, not really directly nursing questions, but this is what you expect in a client with anemia. So now you understand that a client with anemia will have intolerance to the exercise, and you need to plan in your nursing care plan frequent periods of rest spread along the day, because it's a person that have decreased transportation of oxygen, decreased production of ATP, which is the reason for having oxygen transported, and for that reason decreased energy to do activities. So those are examples how a better understanding of the of the physiology could help you with this stuff. Okay, the amount of blood that is arriving here to be pumped is called preload, and is measured mainly with the central venous pressure. the resistance that opposes to the blood to be speeded, um, to be pumped forward, is called afterload. So the heart needs to move the blood in this direction, but need to overcome, need to defeat the opposition of the blood pressure that is here. The blood pressure is the pressure of the blood here. If you want to move the blood here, you need to defeat, you need to overcome the blood pressure. And this blood pressure is going to be given mainly by the level of opening or closing, okay, of the blood vessels, of the addition of all the mid-sized arteries, the billions of mid-sized arteries that we have in the body. You know that when those arteries are open, it's called vasodilation. When these are closed, it's called vasoconstriction. You know that it is mainly responded to the sympathetic nervous system, the alpha receptor of the epinephrine. That alpha receptor produce vasoconstriction. Okay, and you know, if the person has vasoconstriction, it's going to be very difficult to move the blood through those narrow blood vessels. If the person has the blood vessels open, it's going to be much, much easier to the left heart to move the blood forward. That's why in the treatment of a weak heart, I mean, in the treatment of heart failure, vasodilators like the ACE inhibitors have a cornerstone, function, because producing vasodilation will make the work of the heart much more easier, because we will much easier even for a weak heart to move blood with opened blood vessels. And it's important because, sadly, when you have heart failure, the brain activates the sympathetic nervous system, producing vasoconstriction. And it's like, that's why in the past, heart failure had so much mortality, so bad prognosis. In the past, guys, even when maybe before I was a student, heart failure was a, a you know a death penalty. Now it is possible to survive more with heart failure because the introduction of those concepts, the use of vasodilators, not only diuretics and dioxin, but the introduction of the vasodilators, okay, balance vasodilators like the ACE inhibitors, and even the use of small doses of beta blockers to counter this activation of the sympathetic nervous system have brought a incredible improvement of the survival of people with heart failure. So make it simple. The main symptoms of right heart failure are going to be dependent edema. I insist in the word dependent because it's going to depend. It's going to depend of the position of the client. If the client is sitting, the dependent edema is going to be in the legs. If the client is supine, is resting, the edema is going to be in the back. Hepatomegaly, which is an enlargement of the liver, was explained. So you are going to palpate a bigger liver and a tender liver. Even in the severe cases, you can have ascites. The neck vein distension is classical, even is represented here in this picture. Okay, you know that we measure this neck vein distension, and we discussed in the class of assessment, placing the clients at 45 degrees elevation, resting in bed at 45 degrees of elevation. The weight gain, okay, the anorexia that can produce the enlargement of the liver, and the nocturia. These are curious phenomena when the client has edema in the legs and go to bed at night and elevate the legs, reabsorb the edema, having these increments of the urinary output. The left heart failure that can occur concomitantly at the same time as the right heart failure, and is the usual. Okay, no matter that the anchors demand you to discriminate the symptoms originated by each side of the heart, they can be concomitant, can be at the same time. produce mainly manifestation in the lungs. Dyspnea that can be initially at efforts, then evolves to orthopnea, and end with pulmonary edema. The pulmonary edema is going to produce this cough and frothy blood tinged sputum, a pink and frothy sputum. And there is a condition called paroxysmal nocturnal dyspnea, PND. Okay, I wrote that here, paroxysmal nocturnal dyspnea, that is well known. It's mentioned in the book, in the libro. Is mentioned in the book, but until recent, never heard it was mentioned in English. But now I know that is tested. If you know what is this paroxysmal nocturnal dyspnea. Let me tell you something. This is a person that have right and left heart failure. This person is during the day sitting because he's sick. During the day, the legs are very swollen, okay, because he's having this combined global heart failure. At night, go to sleep. Okay, go to sleep. So go to bed maybe with two pillows. Go to bed. Okay, go to bed, but elevate the legs with a pillow because also the legs are swollen. No? And then this liquid is reabsorbed. So now the liquid that was in the legs is in the circulation. Yeah, you know that can reach the kidneys and then can start making the patient getting up to pee more frequent, but it's also reaching the lungs. Need to reach the lungs. This liquid is here and is reabsorbed, and now is reaching the lung. So now at night, when this liquid is reabsorbed, the person will have more liquid, more pulmonary edema in the lungs. Make sense? So now the person is going at 12 at 1 a.m. is going to wake up with a severe pulmonary edema and is going to wake up, if you're not very short of breath, coughing with pink frothy sputum, and this is the paroxysmal nocturnal dyspnea. Dyspnea because it has shortness of breath, a severe shortness of breath. Nocturnal because it is at night, occurs at night when the clients go to bed and elevate the legs and reabsorb the edema that was pulling the legs. And paroxysmal because it wakes a decline up suddenly. Paroxysmal means sudden. Yes, so it's the paroxysmal nocturnal dyspnea. If we learn the meaning of those words, okay, if we respect the meaning of the words, then we don't need to memorize. We only recognize. You don't need to write in the English. You only need to recognize. Paroxysmal sudden nocturnal at night dyspnea in a client with neck vein distension, legs swollen, crackles. Oh yes, this is the client that go to bed more or less, and then when the edema of the legs is reabsorbed, now the liquid that was in the legs now is in the lung. The liquid in the lungs doesn't impair the breathing, but now the liquid in the lung impair the breathing. That's why the dyspnea is paroxysmal, because the patient wakes up suddenly, very short of breath. Okay, easy. You don't need to complicate that. Okay, um, uh, I think that I mentioned with you, okay, that fatigue and confusion is part of the decreased cardiac output in left heart failure. The decreased urinary output, the decreased renal function is a manifestation of the decreased cardiac output. Remember that I explained that. The left heart need to pump the blood to the kidneys, need to pump the blood to the brain, need to pump the blood to the muscles. So you expect foggy brain, you expect weak muscles, and you expect a decreased urinary output. This is what is referred here to fatigue, confusion, and decreased renal function. But then remember that in assessment, we mentioned about the S3, and we say that the S3 equals in a person at risk, okay, heart failure. So ignore what we taught you before, that yes, S3 can, as an exception, not as a rule, be found in normal people, okay? So understand that a person that is with signs and symptoms of heart failure, that is not only S3, is at other symptoms present, other signs present, the presence of S3 translate an enlarged heart, a cardiomegaly, and is a manifestation of heart failure. And this is the extra sound that is added after the S2 in the auscultation of the heart. There is a lab test that you need to know or remember that is associated with heart failure. Is a protein, is a peptide that is produced by the body, but especially is produced in the atrium, and it's called BMP, B-natriuretic peptide. Okay, so this is the name. It is not important. The name, it can be abbreviated BMP, and is a peptide produced by the heart when there is heart failure. And you and me, well, we don't have heart failure, have a very low level of this peptide, very low level, very low level. But if, God forbid, any one of us develop heart failure, will increase significantly. Uh, the elevation of the BMP in heart failure can reach the order of the thousands, but has been accepted by convention that elevation above 100 picograms per milliliter will suggest should yes, support the diagnosis of heart failure. A value below 100 rule out, discard the diagnosis of heart failure. So you can have a doctor that is having an old client that is very old, has COPD because it smoked a lot, has a pneumonia because caught the flu and is complicated with the pneumonia, is hospitalized. But this person also has history of heart failure because maybe it has a previous myocardial infarction, whatever, hypertension, whatever. So the heart has been previously damaged. And the doctors want to know if this shortness of breath and this hypoxia um, is only due to the pneumonia and the COPD, or is also complicated with heart failure. So the doctors can order the BMP. If the BMP is below 100, this person doesn't have heart failure. It's only the COPD and the pneumonia. So the treatment is centered in the COPD and pneumonia. But if the BMP is above 100, then this person, apart of the COPD and the pneumonia, has also heart failure. So the doctor need to include treatment of heart failure added to the antibiotics and bronchodilators needed for the decompensation of the COPD. So this is the application. The BMP has been tested, so have that in mind. Remember that nurses can measure central venous pressure, which is the measurement of the bulimia, of the preload, okay? But doctors can do that with a more sophisticated, catheter that is longer, enters inside the heart, enters inside the pulmonary arteries, and enters in a branch of the pulmonary artery inside the lungs. So doctors can measure the central venous pressure, can measure the intracavitary pressure, can measure the pressures in the own pulmonary artery, and can measure the pressure in the capillaries, in the branch of the pulmonary arteries. This pressure here is better than the central venous pressure. Is more precise, give a better information. Okay, and for that reason, doctors can do that if they consider necessary. Nevertheless, this is not in the scope of practice of the general entry-level nurse. Is in the scope of practice of the doctors and the scope of practice of the specialized nurse. So I don't insist a lot in those measurements of the capillary wedge pressure, the capillary pulmonary wedge pressure, and it's the stuff because it's not expected to be the most important question that you could have in your English. Is more doctor business, is more a specialized nurse business than an entry-level generalist nurse, which is the test that you will have. Maybe the central venous pressure is more probably, and I seen that in question. So a client with a central venous pressure in 18 centimeters of water receiving IV fluids, what you need to do, you need to stop the IV fluids and call the doctor. Why? Because it has too much liquid in the veins. It has 18, a lot above 10, no? 18, and is receiving more fluid. You need to stop this fluid. Makes sense? This is nursing business. This is entry-level nursing business. While the ICU measurement with Schwann-Ganz of the pulmonary pressures, I think, is more to the role of the specialist nurse or the physician. That's why I try to discriminate what is basic, important, priority for Nclex, what could be left to be learned later, depending on the specialization that you decide to take. But there is basic treatment of the heart failure you need to know. So what is a priority? Remember the orthopnea. Remember that the patient is not tolerating the flat position. Please, sometimes clients cannot move. Clients are critically ill. So don't forget that you need to raise the head of the bed because we have clinical beds. And if we don't have a clinical bed, we can sit the clients or we can use pillows to make the clients more comfortable. So raise the head of the bed is an immediate intervention. This intervention immediately, instantly will bring an improvement of the symptoms because will clear an important percentage of the upper part of the lungs of liquid and should be before oxygen, before any other intervention. Of course, then after doing that, you can add oxygen if the client is having hypoxemia as is expected. Just you also expect that these clients that have a heart failure will have fluid restriction. So we need to learn that in the majority of the cases, abundant fluids is okay, is recommended. You can do that. But there are certain diseases in which fluid is restricted. Heart failure could be one of those situations. Renal failure could be another situation. A client with a hyponatremia, dilutional hyponatremia, like the syndrome of inappropriate antidiuretic hormone, could be another example. So it is true, 90% of the clients benefit from increased fluid intake. But there is a percentage, there is a number of pathologies that have fluid restriction, and we need to start, learning, building this knowledge if this is not clear because is going to be tested. You cannot encourage fluid intake to everybody. There are people that are contraindicated, are limited amount of fluid. And the same way, a low sodium diet because generally those clients will be receiving potent diuretic, and the most potent diuretics are the loop diuretic. I mean, furosemide, bumetanide, torsemide, see, that are potent, but at the same time are potassium wasting diuretics. Then you anticipate that you need to replenish, you need to recover the loss of potassium induced by those diuretics with a diet high in potassium. So this is the dietary modification that you expect in clients with heart failure. Restriction of sodium, but increment of the potassium. The monitorization of the weight is super important. It's much, much better than be checking for pitting edema, etc. And then you expect that the doctor will order diuretics, as I said before, potent diuretics, loop diuretics. You expect that the doctor order vasodilators, especially ACE inhibitors, the prils, to improve the, um, the, the, the cardiac output, decreasing the resistance or the afterload, opposing the pumping of the heart. Low doses of beta blockers precisely to control this exaggerated response of the sympathetic nervous system. And occasionally, each day, more rarely, you are going to see the dioxin order. Dioxin is a medication that is inotropic positive. It means inotropic positive is an inotropism, okay, positive. Is inotropic means that makes the heart contract, the muscle of the heart, the myocardium contract more energically, stronger. Yeah, the digoxin can do that, inhibiting the sodium potassium pump and increasing the concentration inside of the muscle heart of calcium. Calcium enhance the contraction. That's the mechanism. Nevertheless, dioxin have a very narrow therapeutic range, so has a high risk of toxicity. And the evidence, there is something called evidence-based practice. that sometimes something that looks logical, that makes sense, the reality, the placing this intervention into practice demonstrate the contrary. And then this is the result of the research of the clinical trials. So the accumulated experience, the evidence of the use of dioxin is that in reality increases the mortality of clients with heart failure. So the decision of how using dioxin need to be carefully determined by the physician, and is each day you see that is used less frequent. Nevertheless, can be used, and if it can be ordered by the doctor, this is a his or her work. Okay, this deciding if using this medication together with deciding that together with the client. No, if the doctor decides to use this medication, we need to know the medication and to know the toxicity, because it's our responsibility to detect. Okay, if the medication is harmful, is becoming is harming the client, so is producing toxicity in the client. Morphine. I want to talk a little about the morphine. Morphine is a medication used in the treatment of the pulmonary edema. This crisis, this emergency in which the client is having this severe dyspnea, is having this severe orthopnea, is having cough and spitting off a pink frothy sputum, the pulmonary edema. Why morphine is used in those cases? First, because the patient is going to feel much, much better, because morphine decreases the shortness of breath, okay, the hunger for air that produces the pulmonary edema. But the second, because the morphine is a potent vasodilator. And being a vasodilator, dilating the veins and dilating the arteries will produce an acute, immediate reduction both of the preload and the afterload. So will decrease the heart work, will decrease the heart demands. You understand? And as a consequence, the heart will have, a better function because it needs to work less. So morphine is a cornerstone of the treatment of pulmonary edema, not the heart failure as a chronic treatment of heart failure, but the acute treatment of pulmonary edema. And yes, at the end of this, we will talk a little more about the pharmacology, but this is more or less the way of managing heart failure uh, by the providers. Also, we need to have a little concept of pediatrics in cardiology. And you know that in the pediatrics cardiology, it needs to start with malformations that can occur during the development of the fetus in the uterus. And those are called congenital malformations. You know that these congenital stuff are not genetic, are not hereditary, so are factory defects that occurs during the complex fetal um, embryo development of the heart. It's a very complex development of the heart. The heart starts like a tube, and this tube start folding and twisting in a way that is very complex, and it's so complex that can have a mistake, and then can have malformation. You don't need to be, as a entry-level nurse, an expert in congenital heart malformation, because it's practically a specialty. But you need to have a general idea. If a baby is born with a damaged heart, let's see, let's use this term, which is not very appropriate, but it's easy to understand. A not perfect heart, a congenital malformation. There are many. Then what you are going to have is mainly a failure of pumping, a failure of pump. And uh, the baby will present mainly signs and symptoms of heart failure. Uh, the the baby will have a heart rate that would be um higher than normal. So in 2 words, we'll have tachycardia, and the baby will develop intolerance, lack of tolerance to the exercise. And you can ask yourself, okay, a baby, a newborn, a 1 month old infant, what type of exercise can do? Okay, the main exercise that a baby can do is sucking. So maybe you don't believe it is difficult, but yes, for a baby, latching to a breast and sucking the milk that is inside this breast is a physical effort. And this is the concept that you need to understand and accept. So the main manifestations of heart failure will appear in the baby during exercise, and the main exercise that they do is sucking. In 2 words, the main manifestation is going to occur while feeding. So also, of course, when they are crying, when you are obtaining a specimen of blood, sticking their heels, etc., of course, they are going to cry. If they are hungry, if they are upset, if they are cold, etc., they're going to cry. The way of communicating, but mainly through feeding. Okay. So what you are going to observe is a mother that has a beautiful baby because those malformations can be hidden, maybe have not been yet diagnosed, and maybe it's the nurse the one that starts suspecting that this baby could have a problem in the heart, expressed as heart failure, and it's the nurse that requests the doctor to examine the baby with more detail. And this is the scenario that is presenting to you in Nclex, that you are suspecting a congenital malformation. Now, it's going to be a mother that comments to you, tells you that the baby is hungry, as normally babies are, and then she puts the baby to suck, okay, to breastfeed, but short after starting breastfeeding, the mother notices that the baby starts sweating, and the baby interrupts the feeding, the breastfeeding, because sounds or looks like short of breath. So doing the exercise of feeding, the baby becomes overcome by the shortness of breath, the dyspnea of the heart failure, and then start sweating and interrupt the feeding. When the baby interrupt the feeding because has a small amount of food already in the stomach, so it's not very hungry, so some milk was already fed, the baby do or does what babies do, which is sleep. Sleep. So the baby falls asleep. But this amount of milk is too small. So short, very short, okay, very soon, the baby will start crying again because it's hungry. So after 15 minutes, 20 minutes, half an hour of being breastfed, the baby who interrupted the feeding and fell asleep is going to cry again for food. And it's going to repeat every half an hour, and the mother is exhausted. And this is the presentation. Of course, this baby, you notice that is not gaining weight as expected. So it could be an organic reason for failure to thrive, which is the term that we use when the babies are not gaining weight as expected, okay, are not growing and gaining weight as expected. And you notice a failure to thrive in a baby that is frequently hungry but interrupts the feeding. This the presentation. This is how the way that they present the the case study, the clinical situation, and how you need to suspect that this baby could be having heart failure because this manifestation. This is the most commonly tested aspect of congenital malformation. Um, the congenital malformation have two main type or classifications, and is the one that produce cyanosis and the one that don't produce cyanosis. The most common congenital heart defects don't produce cyanosis, so it can be hidden, can be not yet diagnosed. the 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 right atrium and the left atrium and the right ventricle and the left atrium should be separated by a, a wall. It's called septum. Sometimes there are holes, abnormal holes in those walls. Imagine that you live in an apartment and you have a hole in the wall that separates your apartment from the neighbor. Okay, so something like this. When this occurs, of course, the heart is not perfect, it's not working perfectly, then the heart can have a heart failure, but there is no cyanosis because always you'll see that the left heart that has higher pressure will be shunting blood to the right heart and you never see cyanosis. What you have is an overload of the pulmonary circulation. It's not important. Those holes are called atrial or ventricular septal defects and are the most common. The most common of all the congenital malformation is the ventricular septal defect. Of course, it's going to depend on the size of the hole. If it is in a small hole, small symptoms. It's a big hole, a big defect, big symptoms. Okay, so everything is going to depend. Okay, and it's beyond the entry level nursing, so it's not the most important. There are other, just to mention this, I don't think it's going to be tested, but there are other acyanotic congenital malformation, like the persistent of the ductus arteriosus. This is a tube, a communication that normally exists between the aorta and the pulmonary artery here. You see here, this is the aorta, okay? And this is the pulmonary artery. And there is in the fetal life a tube, a communication between these two. Why? Because the circulation during the fetal life is totally different from the adult life, you know? And this duct should close soon after the baby is born. Once the baby is born, there is a drop of the level of prostaglandins in the blood because separates from the mother, and the mother doesn't send more prostaglandins to the baby. And of course, the pressure on the resistance of the lungs, the pulmonary artery decreases, and this is what stimulates to close this duct. So the majority of the baby is closed. Sometimes it doesn't close, and it is called persistent. So it doesn't close, persistent. The persistent because doesn't close. Ductus arteriosus is going to produce a murmur. It is a murmur that is called machinery murmur because it's going to be something like and looks like a machinery murmur. I don't think it's going to be tested. Sometimes there is a malformation that is also acyanotic, but it's not inside the heart, is in the aorta. The aorta is a pipe that leaves the left ventricle and goes upward, but then make an arc and goes downward. Here is going to produce the arteries that go to the upper extremities and the carotid, okay? And the carotid arteries, the subclavian arteries, and then continues downwards. Okay, but sometimes there is a malformation in which the aorta is very narrow, extremely narrow here, okay, in this portion. After, after the carotid arteries for the brain and the subclavian arteries for the upper extremity for the arms have been already originated, okay? So this narrowing in the development of this pipe of the aorta here is called coarctation of the aorta. This is going to produce a normal pressure in the carotids, a normal pressure in the arms, but a decreased blood pressure in the lower extremities. So you notice that the pulses and the blood pressure in the upper extremities are strong, but the pulses and the blood pressure in the lower extremities are very weak and decreased. And this is the finding in this congenital malformation. Uh, the the manifestation is the same. Is a baby that looks normal, is pink, is not has no cyanosis, and so it's well oxygenated, and maybe has a murmur. So there is a shh, shh, shh in the heart, a murmur. And you notice that the baby is presenting signs and symptoms of shortness of breath when sucking, when breastfeeding. The, the malformation, the pre-cyanosis, is called tetralogy of Fallot. There are many other malformations, but you don't, those are the most common. The tetralogy of Fallot is so complex that you don't need to know what is happening in the heart. The same that's in here. You don't need to know those details. But the interesting is that there are four. That's why it's called tetra. Tetra means four malformations present at the same time. You don't need to know in details those malformations. But what is important to know is that blue blood, I mean, not blue blood, non-oxygenated blood is going to mix with the oxygenated blood in the left ventricle that is pumped to all the body. For that reason, those babies, since they are born, will have a purple mucosa, purple lips, purple tongue, purple mouth mucosa, purple nails, have a central cyanosis. And when there is chronic cyanosis, the the clients compensate increasing the amount of hemoglobin and red blood cells. So they have polycythemia. And they develop a deformity in the nails that is called clubbing, that it even can be seen in the nails of this girl, okay, if you enlarge this picture. So this is the clothing and polycythemia and the cyanosis that you are. So you are going to have a baby that is purple, it has cyanosis, and with pass of the time, if this is not corrected surgically, will develop clothing, and the hemoglobin will be very high. This is the presentation. And it's a baby when it's auscultated has a murmur in the heart. And when the baby is feeding or exercising, will present shortness of breath. This is the presentation of a baby with tetralogy of Fallot. This cyanosis is permanent, is all time present, and is, as I said, in the mucosa in the center of the body. But in certain moments, of course, those moments are the moments in which the child, the baby or the child is exercising. The baby will present in crisis, an exaggeration of the cyanosis. This is called hypercyanotic spells or hypercyanotic attacks. When they occur, when the child, because look at this child is big, has been left grow with the defect, so is walking. Yeah, so this child is smart, this child is happy, this child is running, is playing, so could be running because he's playing with the siblings, but then because the heart defects becomes very, very extremely cyanotic. Yes, and is having a hypercyanotic spell. Why? Because was running, was exercising. But this child is a baby, and this child is developing a hypercyanotic spell. Why? Because was feeding. Why? Because was crying, because you were drawing blood. So now you were drawing blood to the child in the heel. The child becomes very upset, start crying, and the crying is an exercise and develop a hypercyanotic spell. If there is a child, the scenario that you can have in a question, a child that is already more than 1 year, is ambulatory, is walking, the own child learn that if the A squat, but is squatting, adopting this position, no? This position, no? Is squatting. Yes. So if they squat, the the pressure that squatting exerts in the abdomen will decrease the blood return, the blue blood return to the heart, and the cyanosis improve. So in two words, if you see that the child is developing because was running a hypercyanotic spells and you see the child squatting, respect the position. This is the answer of this question. Leave the child in this position. this position improve the cyanosis. But if you have an infant that is unable to squat by him or herself, you need to mimic the squatting. So you are going to flex the hip and the knees, approximating the, the knees to the chest. This is a knee chest, okay, position. Yes, knee chest, because the knees are going to be, trying to keep the child upright, and then flex the knees and the hips toward the chest. Okay, so it's like making the child a squat, and those are the classical questions of this. Take care that they have been also tested if they have clubbing and if they have polycythemia. Kawasaki disease is also a pediatric disease because it tends to occur with children less than 6, 8 years. Is rarely and older than that. Kawasaki disease can affect the heart. That's why it's included in cardiovascular. Kawasaki disease is autoimmune, so it's the immunity, uh, white blood cells and antibodies and cytokines wrongly attacking part of the body. We don't know really why this happened. We don't know really why it's more frequent in children, small children. We don't know why it's more common in males than in females. Okay, but it happens, period. And it's important to recognize this condition. Kawasaki disease it starts with fever. Fever is the first symptoms of Kawasaki disease. The fever can last several days and has not evident origin. And then soon appears the rashes, the enanthema and the exanthema. Enanthema means that the mucosa, where is mucosa? In the mouth, there is mucosa. In the mouth, inside the mouth, there is mucosa. In the eyes, we have mucosa. Also in the genitals and the anus, we have mucosa. So yes, the mouth, the eyes, the lips, the mouth, the lips, the tongue, the eyes, and the genitals can become inflamed. Appears an inflammation of the mucosa. So there is a mucositis. It's very evident, very early, the pink eye without secretion. There is not a purulent or mucus secretion, just pink eye, the congestion of the conjunctiva, and the inflammation in the mouth and the genitals. And this inflammation of the tongue will produce a prominence of the papa, the taste buds, and it is called strawberry tongue because mimic, the aspect of the strawberry. Um, this is what appears, and of course, a rash in the skin that seems look like the rash of the measles. Okay, very similar to the rash of the measles that is seen in all the skin of the body, disseminating all the body. All the body has the rash. If it continues, the fingers get swollen and later will peel the skin. Okay, the lymph node enlarge a lot, and the the heart develops inflammation. Inflammation. This is inflammation of all the heart. Okay, so this is the presentation of the Kawasaki disease. There is not a specific test to diagnose Kawasaki. It's a clinical diagnosis. Of course, there is blood changes, but not unique, not exclusive. So the doctor do blood work, will have increased C-reactive proteins, increased lymphocytes, etc., but it's not exclusive. And based in this clinical presentation, the doctors decide it is a Kawasaki disease. Kawasaki disease has a very good prognosis if it's properly treated. It is early diagnosed. If it is not diagnosed early and the treatment is delayed, then the heart can develop aneurysm in the coronary arteries. And these can produce problems, long-term problems, because those coronary arteries can develop clots or dissections and can produce myocardiopathy and can produce myocardial infarction, dysrhythmias, etc. So for that reason, it's important to diagnose because those symptoms, the Kawasaki disease, and um, and to receive the appropriate treatment. Uh, it's not contagious. It's a standard precaution, and this is the stuff that you need to know. Um, I don't think you are going to have a question in Nclex, a part of a possible case study, uh, of Kawasaki disease, because you are not going to be diagnosing Kawasaki disease. It is going to be more doctor business, but you are going to collaborate with the treatment, and there is a lot of material to test a nurse in relation with the treatment. The treatment of the Kawasaki disease to prevent these heart damage, etc., is based in two substances. One is aspirin. Aspirin at high doses is administered to children with this fever. You could say, how can we give aspirin to somebody with fever? This can produce the Reye syndrome. No, there is Reye syndrome occurs only if the fever is for flu, influenza, this virus that had vaccine, influenza, yeah, or varicella, chickenpox. Yes. The problem is that influenza and varicella produce fever. And lay people, I mean parents, are not able to differentiate, cannot differentiate a varicella, a flu from a Kawasaki. So it's better to tell all parents, don't give aspirin to your children with fever to avoid this catastrophic lethal condition called Reye syndrome. Yeah. But doctors know that this is not varicella. This is not flu. This is Kawasaki. And then they order high doses of aspirin. These high doses of aspirins are going to be taken for several weeks. It's not lifelong, several weeks. And later are going to be discontinued. Um, because the dose is high, there is a possibility of developing a toxicity by aspirin in the child. And we give the aspirin, and our responsibility is to recognize if the child is developing toxicity by aspirin. You know that the subacute toxicity by aspirin is called salicylism, and an early manifestation is tinnitus. And it's a classical question of pharmacology, which is an early manifestation of toxicity by aspirin in people receiving aspirin at high doses. And there's this ringing in the ears or tinnitus. Um, is this is because the aspirin given a high dose for a long time is ototoxic and even can produce deafness. Of course, the acute toxicity of aspirin is different. It's the one that produces ABG's alteration, so a mixed acid-base disbalance, a respiratory alkalosis combined with metabolic acidosis, hypotension, shock, renal failure, and can be potentially lethal. But it's different. This is the salicylism, and you receive for several days in a subacute fashion high doses of aspirin. The other implication is that this child with Kawasaki, meanwhile, is receiving the aspirin, cannot receive the flu or varicella vaccine until stopping the aspirin, because there is a possibility of developing a Reye syndrome if you give the flu or varicella vaccine while taking the aspirin. But remember, it is just for a few weeks. So postponing this vaccine for a few weeks generally is not going to be a big deal. Okay. But it depends. It depends on the situation. Doctor will need to decide. There is an epidemic of flu. Will need to decide what to do. But this is what can be tested, have been tested. That you need to postpone to give that later, the flu and varicella vaccine when the client stops taking the aspirin, which is easy to understand. The other treatment of the Kawasaki disease is the administration of antibodies, immune globulins. Immune globulins are antibodies that can be artificially prepared in vials and can be bought in the pharmacy, to make you understand that those are immune globulins, antibodies that can be extracted from plasma of donors or can be synthesized artificially. So antibodies artificially created are administered intravenous to those clients. Are the therapy is called IV immune globulins, and this has a positive effect in the disease, and shorten the disease and prevents the damage of the heart. Those immune globulins, also create a limitation in the schedule of vaccination of those children. When we inject immune globulins to a person, this immune globulin will survive, will stay active in the body for several months, and this is a form of passive immunity that is injected. No, it's similar to the passive immunity transferred by the mother to the fetus when the fetus is in the uterus. Is in the uterus. It's a passive injection of the mother immune globulins through the placenta to the baby. In this case, it's not through the placenta. Is one injection, IV injection of immune globulins. But then those immune globulins contain antibodies, defenses that will kill the viruses that form the live viral vaccine, the MMR, I mean the measles, the mumps, and the rubella, and the varicella. Those are live virus vaccines. The virus need to be alive, weakened, but alive to produce immunity. If we give this live virus, if we inject this live viral vaccine to a person that recently received immune globulins, and those immune globulins are already present in the body, in the blood of the clients, this immune globulin will kill the virus, and the patient will not be vaccinated, will not develop immunity. For that reason, children with Kawasaki disease that receive immune globulin as part of the treatment of this disease must wait 11 months to receive the live viral vaccine doses that are due. So summarizing, because meanwhile are taking aspirin, no flu, no varicella vaccine, because varicella and flu are the one that can produce the Reyes syndrome. And the live viral vaccines, MMR and varicella, need to be postponed 11 months because otherwise the vaccine won't work. And those are the most common questions in English that nurses need to know about this detail of the Kawasaki disease. Another condition that is seen more frequently in children and young adults is the rheumatic fever. Rheumatic fever is also an autoimmune disease, an autoimmune disease. So the immunity, um, the the yes, the immunity, the antibodies, and the white blood cells get confused and attack the body as a confusion. In this case, we know that the trigger of this confused immunity, this wrongly aimed immunity, is an streptococcus infection in the throat. So this is the famous strep throat. Streptococcus A infection of the tonsils or the throat can later, even weeks after the ¿cómo se llama? The tonsillitis, the strep throats have been already resolved, can trigger a wrong immunological response that can attack the joints, the lymph node, the skin, but especially the heart. So the rheumatic fever is called rheumatic because it produces rheumatism. So produces inflammation of the joints. But this inflammation of the joints is transient. Those antibodies attacking the joints is just for some days. Can produce other symptoms, even in the nervous system, but is self-limited, can subside alone without treatment. But the part of the inflammation that includes the heart, the inflammation that occurs in the heart, can leave consequences, can be sequelae. Is at the level of the valve. The inflammation this autoimmunity produces in the mitral valve, that is between the left atrium and the left ventricle, and the aortic valve, that is at the exit of the left ventricle and the aorta, uh, can produce permanent damage of those valves. And the person can be left with an incompetence or a stenosis of narrowing of those valves. Those valves are placed there with a purpose to prevent the blood from going backward after being moved forward. So now that those valves are incompetent or too narrow, they are going to produce serious problems, depending, of course, of the severity of the damage. And those persons that suffer rheumatic fevers can be left with a murmur that didn't have before and with a heart failure that didn't have before. During the acute attack of rheumatic fever, doctors are going to look for the arthritis, the fever, the history of strep throat, the inflammation of the heart, etc., that allow doctors, not nurses, to diagnose the condition. So don't dedicate too much to this. Only as a curiosity, know that this produces fever, rheumatic fever, and produces arthritis, rheumatic, to know why it's called rheumatic fever. Understand that it's consequence of a sore throat, possibly a neglected, okay, sore throat, streptococcal infection, and the consequence is this valvular damage. Because this condition, rheumatic fever, can occur weeks after the tonsil were infected, doctors want to do a blood test that becomes elevated if we have a recent streptococcal infection. This test is called anti-streptolysine O, or ASO. It's abbreviated ASO. Okay, it's like anti-streptococcus O. Yeah, anti-streptococcus O. If you have an streptococcal infection recently, in the blood there are antibodies against those streptococcus, one substance produced by the streptococcus, and it's called anti-streptolysine O. Okay, so remember, you don't need to write that, only you need to recognize this test as an evidence of a recent streptococcal infection. By the way, doctor will treat aggressively the infection to minimize the immunological response and will use high doses of aspirin to inhibit the inflammation in the heart with very good outcomes. Nevertheless, if the client is left with a damaged valve, or if the client is born with a damaged valve or an abnormal hole in the body, yeah, uh, you can have a complication called bacterial endocarditis. When we have an infection, any infection. We have an strep throat, we have a wound that is infected, even when we have a rotten tooth or we have a surgical intervention, procedures, I don't know, a curettage, etc. Transiently, bacteria can translocate to the blood and can circulate in the blood of the client. No, so bacteria can circulate in the blood, but immediately the immune system will detect those bacteria circulating in the blood and will destroy the bacteria, and this transient bacteremia has no consequences. Nevertheless, when there is abnormalities, anatomical abnormalities in the heart, like abnormal holes or abnormal valve, when this transient bacteremia occurs, the bacteria can hide from the antibodies, from the defenses inside those anatomical structural abnormalities. I like, sites to hide. And then the bacteria can start growing there, producing an infection and an inflammation of the valve and or the interior of the heart, the endocardium. That's why it's called bacterial endocarditis. This bacterial endocarditis generally occurs in clients with previous structural damage or abnormalities in the heart. For that reason, people that has history of rheumatic fever and damage in the valve, or people that are born with certain kind of murmurs or abnormalities in the in the ¿cómo se llama? In the heart, are going to require uh, prevention, prophylaxis of this bacterial endocarditis when they are having procedures like dental procedures, curettage, surgeries, and colonoscopies, etc., that could bring transient bacteremia. And for that reason, they are going to receive antibiotics, prophylactic antibiotics before those procedures to prevent the endocarditis. And it's called prophylaxis of bacterial endocarditis. Yeah? If this prophylaxis is not carried out and the person develops the bacterial endocarditis, now you are going to have inside the heart and generally in the left heart, you are going to have in the valve, okay, or in the abnormal holes in the body, bacteria multiplying there and forming like a species of clot with fibrin masses inside the heart of fibrin, this substance that produce the clots. And these masses, okay, these like tumors of fibrin with bacteria that are hanging there of the valve contains bacteria, a lot of bacteria. And because the movement, the violent turbulence of the blood flowing in the heart will release fragments, little pieces of these tumors that travel through the circulation to all the body. So now pieces of this mass of fibrin with bacteria will travel to the brain, will travel to the kidneys, will travel to all over the body. And of course, it's producing an infection in all the blood, a septicemia. So what you anticipate, a person with a very severe fever, a person critically ill, and a person presenting embolization of pieces of those clots to the brain, to the kidneys, to the liver, all over. You cannot see the embolization in the brain, in the kidneys, etc., but you can see this embolization in the skin. So you are going to see a lot of nodules and red spots all over the skin that are no more than embolization of those masses. The confirmation of the diagnosis with the culture of the blood. So a blood culture will demonstrate the presence of bacteria in the circulation and the demonstration of those masses through echocardiogram inside the heart. Yes. Of course, those clients, if they are diagnosed early, are treated with antibiotics. Okay? Vancomycin is frequently used. And for a long, long, long period of time. And sometimes the valve needs to be changed. The valve that had been infected and damaged by the endocarditis need to be changed. When they replace the valve with a valve made with plastic and metal, it's called a mechanical valve replacement. And this type of valve, because our metal and plastic, tends to produce clots inside the heart. And for that reason, the client must take anticoagulants, warfarin, oral anticoagulants, warfarin, for the rest of his or her life. But sometimes the valve are replaced with a valve taken from the heart of pig. So um, uh, those are called biological valves. This type of valve don't form clots, and for that reason doesn't require anticoagulants. The other part of the heart that can suffer inflammation is the pericardium. Pericardium is the membrane that surrounds the heart. This membrane is double, so has a virtual cavity between the two layers of the membranes, the visceral and parietal membrane, the pericardium. It's very tough, it's very fibrous, it's difficult to distend. And this membrane is susceptible of inflammation. The inflammation of the pericardium is called pericarditis. Many different things can inflame the pericardium. For example, a myocardial infarction can produce inflammation of the pericardium. For example, autoimmune diseases like lupus can produce inflammation of the pericardium. So the autoimmunity, the confused defenses can attack the pericardium, producing inflammation. Sometimes are infectious conditions, okay? Bacteria and viruses can produce inflammation of the pericardium. Probably the most common form of pericarditis is the viral pericarditis. Sometimes tumors can produce inflammation of the pericardium because metastasis in the pericardium. Sometimes non-treated uremia or renal failure can produce inflammation of the pericardium. Sometimes trauma, okay, penetrating trauma like a stabbing or a close chest trauma can produce, okay, inflammation and bleeding of the pericardium. When a person has pericarditis, inflammation of the pericardium, the main symptom will be pain. Pain in the chest pain, is a little different from the pain of the myocardial infarction because it's more better localized and is a pain more acute, not radiated as the coronary pain to the abdomen, to the jaw, to the arms, is more localized there. And the most important, the one that I want you to remember, is a pain that improves when the patient is leaning forward. So you are going to see the patient, the clients on bed, okay, on bed. You're going to see the client on bed, okay? This is the bed. And you see the patient with a pillow here, okay? A pillow here and on bed, okay? On bed and is always leaning forward. If the patient adopts the recumbent position, the pain will be non-tolerable, will be too strong. So this pain improve leaning forward. Okay, very good. The patient can have fever or not, depending of the cause of the inflammation of the pericardium. When the person has only inflammation of the pericardium, I mean pericarditis, the two layers of the pericardium will be sliding one over the other while becoming inflamed and rough. So is going to be like a two sheets of sandpaper that are sliding, okay, one over the other, and is producing a vibration, a sound called pericardial rub. So the client with acute pericarditis will have the pain. We have the history that predisposed to the pericarditis. The most common is viral. We'll have fever, probably. We'll have pericardial rub. So when you auscultate, you hear the two layers of pericardium sliding one over the other with the contraction of the heart. So it's going to be a two times sound. The systole, whack, and the diastole, whack, 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 whack. So these, grating sounds of the inflamed pericardium sliding one over the other during systole and diastole. But then the inflamed pericardium could start producing liquid. So now liquid start accumulating between the two layers of the pericardium. When the liquid starts accumulating, this sound, this pericardial rub of the two layers of the dry and inflamed pericardium sliding one over the other disappears. Why? Because the liquid separates the two layers of the pericardium. But now that the liquid start accumulating there, at the beginning is little amount of liquid, not too much. So now the pericardial rub disappears, but now you are going to have the heart, the one that produced the S1 and S2, the lopped up, surrounded by an amount of liquid. Liquid is very bad for the transmission of the sound. So now the lopped up, the S1, S2 that we already studied, that are produced by the closure of the mitral and the aortic valve, yes, are going to be heard very low, very far, very muffled, okay? Very muffled sounds. So now that the liquid starts accumulating, this is called now pericardial effusion. Okay, pericardial effusion. Yes, when the liquid start accumulating, the sounds will disappear. The pericardial rub will disappear, and the heart sounds becomes very muffled. As the liquid continues accumulating, the pericardial is going to be very stretched and is not going to give to comply even more. So now the liquid will exert a pressure and a strangling pressure over the heart. The heart needs a space to expand during diastole and fill its interior with blood, and then contract to speed forward to move forward the blood. Now this pericardium is strangling the heart, okay? It's choking the heart, and the heart cannot expand, cannot fill with blood, because now the blood cannot enter. The blood cannot enter. The blood cannot enter the heart. Why cannot enter? Because there is a pressure that is squeezing, is strangling the heart, and the blood cannot enter. You will see that the veins of the neck becomes very, very distended, because the blood is waiting for to enter in the heart but cannot enter. Why? Because this squeezing of the liquid around the heart is preventing the heart from filling with blood during diastole. It cannot expand to fill with blood. But if blood is not entering, blood cannot live. Hmm? Because the blood need to enter to live. So if the blood is not entering, the blood cannot live. So what is going to happen with the cardiac output decreases? What is going to happen with the blood pressure decreases? So you will see that the client is having muffled heart sounds because they're surrounded heart by the liquid. You are going to see that the client have neck vein distension. Why? Because the blood cannot enter. But the client will develop hypotension because the blood cannot live. And if this is not solved, there is a moment that zero blood entered, zero blood leave, and the patient died. And this condition that is progressing there in the heart is called cardiac tamponade. Cardiac tamponade. And the cardiac tamponade is characterized by muffled heart sounds, neck vein distension, hypotension. Okay, the lungs are clear. Why? Because the lungs have no crackles. The lungs are dry. Guys, the blood is not entering. Yes, the lungs are dry. There is no heart failure. Yes, the lungs are dry. And there is something interesting. There is a phenomenon. There is a phenomenon when the blood pressure. Let's talk about the systolic. Suppose the systolic of the client normally is 120. The systolic blood pressure normally should not change too much between inspiration and expiration. When we breathe in inspiration, the blood pressure will be 120. During expiration, breathe out, the blood pressure should be the same, 120. If you have cardiac tamponade, when you breathe in, the blood pressure drops. So this blood pressure will drop to 100 to 90. And then when you breathe out, the blood pressure return to normal. So breathe in, okay, inspiration, blood pressure drops. But in expiration, when the patient breathe out, the blood pressure return back, increases again. So what you are going to notice when the patient breathe in, the pulse, the radial pulse that you are palpating becomes very weak or difficult to palpate. But when the patient breathe out, the pulse, this radial pulse that you are palpating, becomes strong again. So you are going to have this cycling of the intensity of the radial pulse, that when the patient breathes in, becomes very weak, almost impossible to feel. And when the patient breathes out, the pulse becomes strong again. This has a name. It's called pulsus paradoxus. Pulsus paradoxus. And is no more that because the cardiac tamponade, the inspiration produces a drop of the systolic blood pressure more intense than during expiration. Is a manifestation before death of the cardiac tamponade. The intervention, of course, is to remove this liquid as soon as possible. The procedure that removes the liquid is called pericardiocentesis. That is no more than introduction of a needle in the pericardial sac to extract this liquid. And sometimes the patient requires surgery. You know that this cardiac tamponade is considered a priority and an emergency, and for that reason, is frequent presence in clients in questions of prioritization. The other condition that we need to discuss about cardiovascular is the condition that brings you to the ischemic heart disease or coronary heart disease. We know that the heart is a muscle, and this muscle needs to receive blood and oxygen. And this blood and oxygen is received by the muscle of the heart, specifically by the coronary arteries. There are two. Mute your microphone. There are two coronary arteries, okay, left and right. And those coronary arteries are susceptible of a phenomenon that tends to occur as we grow older, that being the arteries a pipe that has a circular muscle, but also has a layer in the interior, a layer in our interior called the endothelium, yeah, a layer in interior, and then this layer, the endothelium, can be susceptible of a phenomenon that um, um, the cholesterol can accumulate under this endothelium. And then little by little, the accumulation of the cholesterol will produce like a protuberance, like a plaque, okay? Like a plaque there inside the pipe that will produce like a lump, okay? There in the interior of the heart that produces a narrowing of the interior of the artery. This is something that grows very slowly, grows in decades, grows very slowly. Start very early. Try to mute your microphone. And you know that it can occur in some people faster, in some people slower. If the person has risk factors to develop these plaques of atheroma fast, these persons are at risk one day of having a rupture. Rupture is that it breaks, no, of the plaque. And when the plaque breaks, then the body will activate the coagulation system and will produce a clot that totally blocks or obstructs the movement of the blood here, so the blood cannot pass. And then all the cells that are depending of this branch of the artery will die of infarction. You know that this can be happening in the myocardium, in the coronary arteries. It can be happening also in the brain. It can be happening also in the arteries of the legs, even in other arteries like the artery of the intestine, the mesenteric arteries, the renal arteries, the own aorta can be having this process. So this is called atherosclerosis. The atherosclerosis is the beginning, the origin of the myocardial infarction. The angina and myocardial infarction is the origin of the stroke, the ischemic stroke, is the origin of other infarction like mesenteric infarction, renal infarction, and is the origin of the peripheral arterial disease. All those diseases are very common in people that are growing older and are diseases that you need to know very well and are frequently tested. To develop those plaques of cholesterol, the person can have risk factors. And you need to know that some risk factors can be modified, risk factors cannot be modified. For example, the genetics is a risk factor you cannot modify, because if you have in your family many people that suffer myocardial infarction or a stroke, especially when they suffer it at younger age, okay, before they are 60s, okay, they are having myocardial infarction or a stroke before they are 60, is a risk factor you cannot modify. Your age is a risk factor, as uh, it is a disease that is rare in young people. It's a disease that starts appearing after middle age, after your 50s, more or less. Yes. And you cannot modify your age. And gender appears earlier in males and later in females. Doesn't mean that females don't have this disease, but appears later than males. Uh, but there are risk factors that can just be modified. For example, hypertension can be modified. You can treat your hypertension. Diabetes is an important risk factor, can be modified. You can control your diabetes. High cholesterol can be modified. You can control your cholesterol. Uh, Smoking, okay, is modifiable. So you can quit smoking. Obesity is a risk factor that is associated with hypertension, is associated with diabetes, associated with high cholesterol, can be modified. Sedentarism can be modified. So their risk factor can be modified. Of those risk factors that can be modified. There is one that you need to know very well because it's frequently tested in English. It's the combination of several risk factors in the same individual, modifiable risk factors in the same individual. And sadly, the problem of this type of individual, that those individuals are young, even children. So you can have a child or an adolescent or a young adult with this condition, this condition called metabolic syndrome, and you anticipate that this person, if doesn't modify those modifiable risk factors, will end with a myocardial infarction and or a stroke and or peripheral arterial disease very young, very young. And this metabolic syndrome is related to one condition, and is obesity. And obesity, it means being fat. It means being weighing more than the normal, okay, is an epidemic. Okay, is an epidemic. Okay, and sadly, it's an epidemic in children, and that's why it's a very concerning aspect. And anchors give a lot of importance to this. And obesity is considered a disease, and is a disease that produces this. This is not any type of obesity. It's a type of obesity that concentrates mainly in the abdomen, which is, by the way, the most common form of obesity. So the accumulation of fat occurs mainly in the trunk, in the central part of the body. It's not so marked in the legs and the arms. It's mainly in the trunk. And for that reason, is this type of person that has this shape, no? That has this shape, okay? This shape, okay? And that's why it's called apple-shaped obesity. There are other type of obesity. There are some, especially in females, that you have this shape, this shape, no? Which is more the shape of a pear, no? Is the shape of a pear, yeah? And the big difference between these and these, the pear shape versus the apple shape that has the highest risk, is the one that represents the metabolic syndrome, is the umbilicus. What you have in the umbilicus, at the level of the umbilicus, you have one measurement, is called waist, no? So notice that the obesity of the apple, the pear shape, has a narrow waist, while the apple shape obesity has a wide waist. So the waist is what defines this apple shape obesity that is so common and is such an important risk factor for this accelerated process of atherosclerosis in the body. So is the waist circumference, okay, the increased waist. You don't need to memorize the normal values, okay? They say that is 35 for women, 40 for men, more than inches, no? But you don't need to memorize that. It's the waist what you need to understand, and the apple shape obesity. Those are the words, the terms that have been in question in English, that if you know that this type of obesity, central obesity, this truncal obesity, is the one that is associated with metabolic syndrome. What happens with people with this type of obesity? Well, these people will have a blood pressure that is higher than normal. You know that blood pressure should be no equal, less than 120/80. So you have those children, you check the blood pressure, they have 128/84. So this is not normal blood pressure. They have already a pre-hypertension. And those people, when you do the fasting blood sugar, is okay. Fasting blood sugar is okay. But if you administer a dose of glucose orally and then you check the blood sugar 2 hours later, will be elevated. They have glucose intolerance, so a pre-diabetes condition. And when you check the lipids in the blood, what you are going to notice is that the triglyceride, those fats called triglycerides, are elevated. And the good cholesterol, the happy cholesterol, the HDL cholesterol, is low. All those details has been tested in English. Remember that you have a lot of cellular apply question, and you have a cellular apply what characterizes the metabolic syndrome. The obesity, the central obesity, the increased waist circumference, high triglycerides, low HDL, insulin resistant, a blood pressure higher than normal, etc. And this is a condition that summarizes, conjugates in the one individual all the risk factors that could be modified for the development of those plaques of cholesterol. We already mentioned, okay, nutrition, but then they insist a lot, if you know, that there are diets that oppose that, so diets low in calories to lose weight, but also diets that are low in cholesterol, diets that help to avoid the development of those plaques of cholesterol. Those are diets that should avoid the fats of animal origin. The main source of fat of animal origin are the red meats, so the beef, and the fat of the dairy, the milk and dairy. So all the animal fats. Nevertheless, the fats of vegetable origin, olive oil, avocado, peanuts, etc., and the fat of certain animals, like for example, the fat of fatty fish, like the salmon, like the cod, etc., fish in general, are considered good fats. Okay, is are unsaturated or monounsaturated fats that are good, but the saturated fat, okay, should be reduced, should be lowered to have an anti-atherogenic diet. Should be avoided the sugar and alcohol, low sodium, high potassium, a lot of vegetables, a lot of fruits, a lot of grains, a lot of nuts, a lot of fish and poultry, yes, that are very useful to increase the happy cholesterol, the HDL cholesterol, and to decrease the lousy cholesterol, the LDL cholesterol, the bad cholesterol. This cholesterol that accumulates here is bad cholesterol, and this is how you're going to apply those concepts. Remember that when you have this partial obstruction of an artery, now the blood can pass. So suppose that here you have a part of the heart that is depending. So this part of the heart is depending of this branch of the coronary artery. But then the amount of blood that is passing here is going to be limited by this partial narrowing or partial obstruction or narrowing of the artery. So meanwhile, the client is at rest and the heart is calmed down, is not working too much, this amount of blood that is flowing here is okay. But if the heart starts exercising, so the patient start exercising and the heart start, increasing its work to catch up with the increased demand of cardiac output of the exercise, then maybe the amount of blood that is flowing here is not enough, and then this area can become ischemic. Ischemic means that there is not enough oxygen to produce the ATP. And when the tissues become ischemic because the lack of oxygen, the localized deficiency of oxygen, this tissue, this part that is ischemic, start producing lactic acid. Lactic acid. The lactic acid has the property of stimulating the nerve that are nearby, producing pain. So that's why when a person has this partially obstructed or narrowed arteries in the heart and they start exercising, they will experience chest pain because the production of lactic acid by the ischemic region of the heart that is depending of this partially obstructed artery. This is called angina. So the angina is characterized by chest pain that appears when the person is doing an exercise, when the heart is working more than usual. Of course, when a person is experiencing this pain, which is intense, it's a strong pain, the patient will stop exercising. So whichever exercise the person is doing will be stopped. So now the need of oxygen of this partially obstructed area of the myocardium returns to minimum, returns to normal, and then the ischemia disappears, the production of lactic acid stops, and once the person stops exercising, the pain disappears. So what characterizes the angina? Chest pain that appears with the exercise and disappears with the rest. This is what characterizes the angina and will be repetitive and will be consistent. So the level of exercise that triggers the pain, the chest pain, will be constant. So suppose that the person has a obstruction that precipitates ischemia when is walking, let's see, for a flight of stairs. It's climbing 4 flight of stairs. So always when they are reaching the fourth flight of stairs, okay, the person presents the chest pain. It is unstable angina, unstable angina. Doctors will treat stable angina um, with first medications to prevent the formation of clots in this space, okay, because it's very bad that a clot forms there. So doctor will order aspirin and low doses or clopidogrel or any other antiplatelet medication, antiplatelet aggregation medication to prevent the formation of clots. Doctor will order a diet modification of lifestyle to stop the risk factor for developing the plaque of cholesterol. Doctors will prescribe statins that are very efficient in stopping the growth of the plaques and stabilizing the plaques to prevent its rupture or see, rupture. And doctor will order medication calm to calm down the heart, to avoid the heart to become too excited, demanding too much blood and oxygen. And the medication that calm down the heart are the beta blockers, olol, no, propanolol, metoprolol, etc., and the calcium channel blockers, especially the non-dehydropyridine like the diltiazem and verapamil. So this is what you expect in a client taking every day with a angina. Of course, doctor will order a tablet to be used PRN as needed of nitroglycerin, because this nitroglycerin, if you have an attack of angina, if administered, immediately will produce vasodilation before and after the heart preload and afterload, and will decrease the need of oxygen of the heart and will produce a rapid improvement of the ischemia of the heart. So this is the basic treatment that you know, just to summarize. But one day, bad luck, the client can have one of those plaques, okay, breaking. And when the plaques break, the platelets that are circulating, okay, inactive in the blood, become activated. The substances that are released when the plaques break activate the platelets, so the platelets will aggregate, forming here over the broken plaque a clot that starts growing gradually. Okay, and of course the platelets will call the fibrin, and the fibrin will come here and also will be added to the platelet to form a clot that could obstruct completely the space left in this narrow part of the artery. When this total obstruction occurs, there is zero blood passing here. So this part of the heart that is depending of this coronary artery will start little by little, layer by layer, dying. The cell will start dying layer by layer. Since this, the first layer to die will be this. The next in 5 minutes is this. The next this. So there is a progression of the infarction of the myocardium that would last as long as 6 hours. So from since the moment of this part of the myocardium start dying because there is no blood arriving here, until the moment that this last layer dies, I mean all the thickness of the myocardium, depending on the artery, has died, can pass as much as 6 hours. This is important because this is the window period that doctors and nurses can have to reestablish with reperfusion the circulation through this. So this clot could be removed, could be either removed or dissolved. So if you have a clot here, doctor through catheterism, that is the introduction of a catheter in the groin that ascend through the aorta and reaches the heart, could arrive here and remove this clot, and even can deploy here like a mesh that is left open, okay, is left open to prevent this becoming obstructed again. This is called stent. This is called a stent. So this is an interventional catheterization, invasive catheterization, which is the best intervention to reestablish the blood flow in a person that has an acute myocardial infarction. Uh, Another possibility, if this resource is not possible, is not available, is if the clot is from here, is to administer intravenous decline, a substance that is able to dissolve the clot, is the thrombolytic therapy, the TPA or thrombolytic therapy. But you have a window period that is very short to do that, a very short period, 6 hours, okay, to benefit from this procedure, okay? So summarizing of all this stuff that we have been commenting, we have risk factors that can be modifiable or non modifiable. You know what they are, and they are summarized in metabolic syndrome. Oh, I forgot. Don't forget that the metabolic syndrome has a physical finding in the skin, which is the acanthosis nigricans. This is this dark discoloration of the folds in the neck, armpits, and between the legs that are part of this metabolic syndrome. And if the obstruction is partial, you will have this angina, which is chest pain when the client is doing an exercise, and it's a constant pattern of exercise, and it's called stable angina. There is a variety of angina that has been sometimes tested. It's called Prinzmetal angina. This is the name, Prinzmetal angina. Also could be called vasospastic angina. Sometimes a person could present chest pain. This chest pain tends to appear at rest. So the person and the doctor suspects this is a myocardial infarction that is not related with exercise. But then when the person go to the hospital thinking that has a myocardial infarction, the cardiac markers, the troponin, the cardiac enzymes don't elevate because there is not death of myocardium. There is not infarction. And when they do a catheterism, they find that the coronary arteries are perfect. There are no plaques of cholesterol inside the coronary arteries. So they conclude that those clients, what they are developing is in certain moments, the coronary artery develop a vasospasm, becomes too narrow because contraction of the circular muscle. And for that reason, they present this pain randomly because vasospasm without atheroma at rest, okay, with normal troponin, normal catheterism, and this is treated with calcium channel blockers. Okay, the treatment of this is with calcium channel blockers, not with beta blockers, with calcium channel blockers, diltiazem, or verapamil. So from time to time, These can be tested. These have been tested time to time. A variation, a variant, a variation, atypical, rare, not common of angina that is not precipitated by exercise, yes, where the coronary arteries are normal. And it's because vasospasm are treated with calcium channel blocker. Clients with this can be tested, okay, with a, the stress test to demonstrate the changes that occurs in angina during the exercise. And don't forget that when there is angina, nobody has died. And for that reason, the troponin, the cardiac enzyme, don't elevate. As I mentioned before, the treatment is with medication, including nitroglycerins, beta blockers, calcium channel blocker, aspirin, clopidogrel, and statins. But when there is a myocardial infarction, it's because the plaque become broken and a clot formed there. This tends to occur at rest, and this will produce chest pain typically. The chest pain is very diffuse, difficult to localize, and tends to radiate to any part of the body. Tends to radiate to the neck, to the jaw, to the maxilla. The patient can think it's a tooth, the one that is producing the pain, can radiate to the ears, can radiate to the right or to the left arm, can radiate to the back, can radiate to the abdomen, making you think it is a problem, abdominal problem, like an ulcer or a cholelithiasis, gallstones, etc. So it's very, mm, um, different variable the way that can radiate the chest pain. But also there are clients, that could have a myocardial infarction without chest pain. So what they experience could be digestive symptoms like nausea and indigestion, bloating, or could be mainly shortness of breath, sensation of shortness of breath, or extreme muscular fatigue, okay, physical fatigue. These atypical symptoms of myocardial infarction are more common in women, in the diabetic clients, and the old patient. What is it true that if you have any client with chest pain, you need to consider this client as a priority, especially if the client has risk factors. So if you have a 18 years old with chest pain, it's not logical to think in myocardial infarction because at this age, there are not risk factors present for myocardial infarction. But if you have somebody 50, 60 with chest pain, please rule out as first option myocardial infarction. That's why chest pain is usually a priority. If at the end it's not the heart, then it's other cause, then okay, no problem with that. When you have myocardial infarction, there are certain changes in the EKG that are typical, are the usual, which is the elevation of the Ed.D segment of the electrocardiograms. Remember that electrocardiogram has the P wave, then a Q, the R, the S, and then a horizontal line that ends in the T wave. This horizontal line is called ST segment. That should be at the same level of the rest of the horizontal lines of the EKG. In the classical EKG of the myocardial infarction, you have an elevation of this segment, and it's called ST elevation myocardial infarction. Nevertheless, they are myocardial infarction that are in progressions, are not totally covering all the thickness of the walls, etc., that could not develop ST elevation, could be called non-ST elevation MI. But this is for the cardiologists. This is not for the nurses. The nurses are going to be dealing with the classical. okay, situation of the myocardial infarction. What is true is that these changes in the EKG, if they are going to occur, will occur immediately the myocardial infarction occurs. So the first test, Nclex question, that should be done in a patient with chest pain should be the EKG. But the best test is not the EKG. Sometimes the EKG cannot identify the MI. Okay, sometimes. The majority, yes, but sometimes no. But the test that is the best is the troponin. But the problem with the troponin, that troponin takes time to elevate. So if the myocardial infarction starts in the time zero, then the elevation of the troponin can occur 2 or 4 or even 6 hours after the beginning of the myocardial infarction. That's why you cannot wait for the elevation of the troponin. Okay, you can before do an EKG to make the diagnosis. And meanwhile, the patient is treated as if were a myocardial infarction. So this is,
Professor,
yes,
I have a question.
sure.
Yesterday in the test, we have a patient that she was a woman. She had all symptoms like chest pain, everything, but all the values were good except troponin. They say that she was 0.6 and the regular was less than 0.1.
Mhm.
And they said after, I don't know, I don't remember the time, she don't have any pain or nothing. That is like a myocardial infarction or was a panic attack,
No, myocardial infarction. Elevation of
right?
troponin occurs in myocardial infarction.
Only that, because
If
they didn't
there are
say, they didn't give
elevation
you
of,
anything else.
yeah, if there is elevation of myocardial of troponin, it's
It was
because
0.6.
there is necrosis. Okay, you need to compare the value that the lab is giving you. Okay, if there is necrosis of the of the myocardial cells, the troponin elevates. You know, we cannot rule out a myocardial infarction if the person has elevation of the troponin. If the troponin is elevated, it's because there is necrosis of the myocardium. Do you understand? And
Okay.
that's obviamente.
Professor, yeah, it was confusing that one because she was 24 years old. That patient that
Okay,
she's
Yeah,
talking
okay.
about.
she was 24 years old.
Yes.
The blood pressure, everything was like in within the range, and the only lab that you can like suspect something, it was the troponin. But and also she claimed that the pain on the chest alleviate, and it was kind of tricky, the question.
Okay, of course, obviously, this is not the typical scenario. It's not common myocardial infarction in a woman of 24 years old. Nevertheless, 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 it's possible. But okay, this is a very atypical case. This is something that characterizes the question banks. That uh, use a typical case, which is not what an entry level nurse should be dealing with, and it's not the classical Nclex style question. You need to understand that we need to discriminate what is an MD, what is an ND cardiologist, okay, versus an other MDs, and what is a nurse, what is an entry level registered nurse. When this is a very personal opinion, Mia, that had been all time, okay, kept. When a question bank start, bringing to the registered nurse, okay, field, atypical cases that compete to the specialty of medicine, there is a loss of horizon and there is a loss of a scope of practice, and it brings confusion, as is evident on you, instead of orientation. This is from my very personal point of view of why we are failing as educators of nurses in make our nurses successful in the Nclex, and even successful at the moment of they're going to work in the workplaces, because we are making our nurses, our students, okay, dedicate time to atypical cases that are decisions that are beyond the scope of nursing, to decide that these clients are atypical with so low risk, with elevation of troponin, was having a myocardial infarction or not. So I protest definitively this kind of uh, frequent, okay, tendency of the banks exploring those atypical patients. I have a big satisfaction when one of the specialists that came to evaluate the school last year, uh, I had the opportunity of discuss this attitude that if we are preparing the students to pass, first to pass the Nclex, and second to be practical with the basic knowledge as an entry-level nurse. And one of the recommendations that we received from this expert was that, okay, trying to discriminate what is a book or a question bank, teaching that is not are not bad, are good, but sometimes they go too specific, too atypical, too difficult cases that are definitely beyond this case. So this example of question that you are presenting to me is very confusing. That you say a 24 years old woman without risk factor presenting an elevation of troponin is bringing you to a very confusing decision that is depends to the expert, the provider, the cardiologist, to decide if we rule out myocardial infarction in this case or not. And I think this responsibility cannot be delegated to the nurse. So I totally disagree with this question because it's confusing you, and the evidence is your reaction, that you are more confused than oriented. Okay. So summarizing, an elevation of troponin supports a diagnosis of myocardial infarction. And you cannot ignore a person, even with a risk factor, that has chest pain and elevation of troponin, because if they order troponin in this 24 years old woman because she has chest pain and they wanted to rule out myocardial infarction, and if the troponin comes out elevated, this woman requires more studies because you cannot rule out, okay, even because the age, okay, a myocardial infarction. I'm so sorry, I cannot discuss this question because I disagree totally, forcing a nursing student, an entry-level nursing student, generalist nursing student, to disguise of this kind of question and decision that are so atypical, etc. I apologize because I'm an educator of nursing, but I definitively, being doing, okay, question banks, etc. And suddenly I feel that I'm studying for the board of medicine, not for the board of nursing. And I think that is a loss of horizon. They lost the limits. The educator, we are sometimes in those, but they are forced to us, okay, because we cannot decide for those questions that appears in a test, no, because there are tests that come from other sources, and that's it. This is what I can tell you about this. Simply that if even
This was HESI, Professor. It was HESI. It wasn't the school. It was a HESI test.
yes, I know all those programs are very good,
Yeah.
but from time to time they comes with some questions that can be really discarded by me because are not helping. By the contrary, are confusing the students. And that's it. I'm so sorry. I apologize in the name of the educators,
No,
but
thank you. We wanted to
it
know
is
because
Thank
that's
you,
the only
Professor.
question
Thank you.
it is a reality that is confusing instead of orienting, of educating. Example like this. Okay, so that's why it's important to know that troponin should be inside the myocardial cells. And if this troponin is a spill to the blood, and when you draw blood from the arms, and this troponin is elevated, it's because cells in the myocardium have died. Biology and this field is very complex. We're trying to teach the basic. There are exceptions to the rule, etc. But the basic that you need to know that elevation of troponin supports the diagnosis of necrosis of the myocardium and myocardial infarction, and is never a nurse is going to assume the responsibility of ruling out myocardial infarction if the troponin is elevated. By the contrary, you need to know that is a something that should make think that the client is having a myocardial infarction. The role of the nurse and the question that I see in Nclex of myocardial infarction is that you should overdiagnose myocardial infarction, that you should not rule out myocardial infarction, that you should be overdiagnosing myocardial infarction. For example, 3 days ago, one Cuban physician that was taking the test for third time, okay, a female, a smart Cuban physician taking the test for first time, commented to me that she was very confused in one question in which was a client, male, middle age, risk factors, having a chest pain that radiated to the right arm. And she was very confused because she was used to know that the usual radiation of the pain in myocardial infarction is to the left arm. This is a misconception. This is wrong. The pain can radiate wherever they want. Okay, and I told you should not be confused. You were guided more by lay, street, okay, knowledge than from medical knowledge. You know that the irradiation of myocardial infarction is very atypical, and even we need to be aware that that sometimes there is no pain and there is myocardial infarction. So the position of the board, the board, no, the Nclex, is that the nurse is having all time in mind that myocardial infarction should be ruled out always. Should be ruled out always. Okay, and this is better to overdiagnose, say, oh, let me keep this client to be evaluated by the physician, because at the end is the physician the one that is going to decide if it is a myocardial infarction or not. Let me keep this client to be evaluated by the physician instead of sending the client home because I consider it's not a myocardial infarction. This is not what the Nclex considers safe. And this question, if the question is intended to make a nurse rule out myocardial infarction in a confused case because there were no risk factor, is counter teaching the student, is disorienting the student. And I'm sorry, it's my opinion, it's my personal opinion. I have been my personal opinion. That's why I was very filtering when I used to do make tests. I was filtering and modifying question because I don't want to confuse my students. I want to give my student a orientation that allowed to pass the anchors, enter to work, and once they acquire expertise in one area, they start learning the exception of the rules. I cannot start teaching the exception of the rule without being taught first the rule. I need you to learn the rule, and then later, when you master the rule, start learning the exception of the rule. This example that you are giving me is an exception of the rule. Okay, so less that that troponin is the definitive diagnosis of myocardial infarction. The problem of the troponin that takes time to elevate, and you cannot have an immediate diagnosis of myocardial infarction with the troponin because it can take 1, 2, 3, 4, 5 hours to elevate. That's why doctors order to repeat the troponin more than once to observe the tendency to the elevation of the troponin. Okay. The treatment of the myocardial infarction, the most important treatment is doctor's treatment, is the revascularization, done as soon as possible. And the revascularization son those that we mentioned, the catheterism to reach the site of the obstruction and to open the obstruction with catheterism and stent is the percutaneous transluminal coronary angiography and stent. PTCA is what they call that. Okay, and should be is the most effective intervention. And in United States is the first that they do in myocardial infarction. Of course, there is a time frame of benefit. The sooner, the better. Okay, and when that is not possible because it's a rural hospital, etc., they cannot do catheterism, then they have the option of fibrinolytic therapy, the tissue plasmin activator. Alteplase is the more frequently used. You have a window period of 6 hours, but the sooner the better. Okay. And when you administer this medication, there is risk for hemorrhage because this medication will dissolve any clot that you have in the body. And for example, if you have a clot in an ulcer in your stomach, you will start bleeding in the stomach when they give you the TPA for your myocardial infarction. And that's why there is contraindication for this therapy, for example, in pregnant women. But pregnant women are not frequently having myocardial infarction, but it's contraindicated in pregnant women. It's contraindicated you have a brain hemorrhage. It's contraindicated you have a recent stroke in your brain, trauma in the brain, recent surgery, etc., because they will make you bleed. Sometimes the catheterism and the fibrinolytic therapies are not enough, and then they need to open the heart and finds the artery that is obstructed and make a bypass. So if the artery is obstructed, okay, is totally obstructed by a very tight obstruction, they take a vein of the body and then they make a bypass. Okay, they make a bypass. Okay, and now the blood that was not able to flow here is going to make this and bypass. Okay, this is a coronary artery bypass graft. It requires open heart surgery and all the care before and after surgery that you know in the perioperative care. Okay, the main cause of dying because a myocardial infarction is sudden death, that you suddenly die during the acute phase, the first 72 hours of the myocardial infarction. Is because clients with myocardial infarction had the tendency to develop ventricular dysrhythmia, specifically VTAC without pulse or ventricular fibrillation. Either VTAC without pulse and ventricular fibrillation are cause of sudden death. And the prevention and early detection, if it cannot be prevented of this dysrhythmia, is basic in the management of the myocardial infarction to prevent the death. There are other causes of complication of the myocardial infarction, like heart failure, cardiogenic shock, even pericarditis and cardiac tamponade. Majority of the clients nowadays of myocardial infarction survive thanks to this reperfusion therapy, where they reopen the artery that has been obstructed. And the client will have to rehabilitation to return to a normal life. It is a common question of the client when they can start having the physical effort of sexual activity. The best answer to that is the doctor should be consulted. Why? Because not all myocardial infarctions are the same. Not all the clients are left with the same capacity of doing exercise. But the classical answer of this question is that if the client after the myocardial infarction is able to climb 2 flights of stairs with having pain or dyspnea, can have a normal sex. So the girlfriend can be living in a second floor in no problem. Here are some pictures to know what is the transcutaneous, percutaneous, transluminal coronary angiography with a catheter that, remove the obstruction, the clots, and deploy a stent. What is a bypass, how they extract the vein from the legs, and how you have a client after this cabbage with a wound in the chest that hurts a lot and drains, okay, to drain the liquid to prevent the accumulation of liquid in the pericardium, and maybe because there is a collapse of one lung. Okay, the next class, the next time that we gather, we are going to be talking about cardiac dysrhythmias. By the way, Nclex makes not too many questions, maybe heart failure, the most common question. From time to time, question of pediatric Kawasaki, the stuff that I mentioned before, and pericarditis, yes. And but the Nclex ones from myocardial infarction and coronary artery disease that you don't send home somebody that could be having a myocardial infarction. This is the question that is more frequent. But this part, the cardiac dysrhythmia, is the heaviest, okay, component of the Nclex, the questions in the Nclex, based in my experience, what you tell me that you have in your Nclex. So we need to dedicate a little to talk about this cardiac dysrhythmia the next time that we meet. Any question, any doubt? A lot, especially after this HESI test. Any question, guys?
No, thank you.
So you understood the
No, Professor.
explanations.
Thank
Okay.
you.
Okay.
Yes.
So then we gather next times and we'll decide, okay, about, okay,